All right, so today's session is part of the Cannabis Research Institute's public research series, an initiative designed to make cannabis science transparent, accessible, and collaborative. Each session brings in leading researchers and practitioners to share evidence-based insights on cannabis health and society, and to help build a shared understanding across disciplines and communities. Today's session. We are incredibly fortunate to have Dr. Leslie Mendoza Temple with us to walk through the Medical Cannabis Competency Framework, a resource that speaks directly to the kind of transparent evidence informed education we're working to advance. And we're happy to be able to have Dr. Leslie Mendoza Temple with us to be able to go through this publication that came out in JAMA. I believe it was late October. Is that correct?
Yeah, early October, JAMA Open Network. Yeah.
Sorry, early October. Okay. And with that, let me now introduce Dr. Leslie Mendoza Temple. Dr. Mendoza Temple is the Owen L. Kuhn Endowed Chair of Integrative Medicine and the Medical Director of the Integrative Medicine Program at the Endeavor Health. She also serves as a clinical professor of family medicine at the University of Chicago Pritzker School of Medicine. Dr. Temple was twice appointed chair of the Medical Cannabis Advisory Board for the Illinois Department of Public Health, first in 2014 and again in 2024. We are very grateful to have her with us today. And with that said, Dr. Mendoza Temple, please take it away.
So we're going to dive right into what is this paper about. And thank you for inviting me here as an innovative group we have here in Illinois, unlike any other I know of in the States. We're lucky to have this in Illinois. So I'm going to talk about how the paper came together, what it is, the actual curriculum. So it gets a bit dry, but hopefully it will be of interest to you because it's definitely interesting to our students and absolutely paramount for our patients that our healthcare professionals know this. I'll give a little teaser on talking about curriculum implementation as we have educators on this in the audience here. It's not, you can't just say, hey, we should put this in med school or in curriculum and suddenly it happens. I'm going to make some suggestions on strategies to increase uptake and talk about multidisciplinary education because we had to focus on physician medical school education because you had to start somewhere in the research. Otherwise, if you get too broad, it gets too difficult to do. So October 7th in JAMA Open Network, this was the list of authors talking about the medical cannabis competencies. This is free access, full text. And don't forget, when you do look at the article, make sure you download the supplementary materials that you have to kind of dig for, in the attachments there, because this is what I'm presenting to you now. The lead authors we met online during the pandemic, and they're Israeli researchers and my colleague from George Washington University. So we actually didn't even meet in person until this conference 3 years later after a million Zooms and emails. So it was a joyous union and reunion for us presenting in Tel Aviv, Israel on the endocannabinoid system and such. So I just want to shout out to Richard Israelowitz, who led this effort from the Radar Center at Ben-Gurion University of the Negev, which is a regional alcohol and drug abuse research center. So they have several of those around the world. And our lead author, Tubi Zolotov from Ben-Gurion and Albert Einstein. In the very beginning of this, the collaborations resulted early on before the JAMA Network article on cultivating 2 issues on medical cannabis in the clinical realm and research articles on educating professionals. So we have been doing a lot of work to lead up to this, thanks to the editor-in-chief, Dr. Kathy Kemper. And also a thanks to our very diverse group of Delphi members. And you can see from just the list of specialties that we have quite a mix. We wanted to make sure the folks on this panel didn't have their own cannabis education products to sell, nor were they really just, we'd pick people who we felt we knew in our circles, but also had experience in either using medical cannabis clinically or they had a strong educational background. So you can see here quite the spectrum from addiction med, ER, family med, geriatrics. We had a representative from NCAM, We have a toxicologist, neurologist, oncology, you name it. We tried to include it all without being so big that it's difficult to get anything done. And our methods, we're using the Delphi method between February and October. A couple of years ago, we had 23 experts, and we did 2 rounds of web-based surveys where we would just people would answer questions anonymously, put in their 2 cents about how the wording of each competency sounded, and we would just sit there and word craft till everyone came to the most agreement. And we then reviewed them over and over again. So this is basically an old method that came out of the Rand Corporation during wartime, to come upon a consensus-based agreement on how to go about a complex topic. And then we rated the competencies on agreement on wording and content on a scale of 1 to 5. And because there was so much agreement in multiple iterations of the competencies, we only had to do 2 rounds. We didn't have to do 3 or 4 because of disagreement. So it was nice not to have to keep going and going because the agreements were pretty strong. So this is the competencies, 6 competencies: to understand the basics of the endocannabinoid system, to describe the cannabis plant itself and its biological effects, the U.S. legal and regulatory landscape, which as we know now, is ever changing. Number 4 is to review the evidence base for health conditions that are commonly managed with cannabis. Now, caveat is that doesn't mean that there is evidence for those conditions. It just means that we know people use cannabis for this. So the list was really comprehensive, but the evidence base is still very in need of lots of reinforcement. Number 5 is the potential risks of cannabis use, recreational or medical, really. We focused on medical purposes. And how do we understand basic clinical management? How do you actually tell a patient what to do or what not to do when it comes to cannabis for medical applications? So those are the 6 pillars. And from them, we generated sub-competencies below them that the Delphi group also weighed in on. And so I'm going to go, and this is the tedious part of this conversation, is those are the 6. And that's all. If that's all you want to know as an educator, just tell me what 6 things I need, and I will take that to my curriculum people, and we'll just develop a nice PowerPoint. You could probably knock all 6 of those out very, very briefly in an hour, but it will be super fast and very surface-based. But we wanted each of those, like the first pillar here of understanding the ECS. You got to know what it is, that it exists. There are enzymes, there's locks and keys and endocannabinoid receptors, and you have to know what it does. Like, that it regulates stress, sleep, appetite, pain, and immune function, that it's basically a part of our homeostasis as living organisms. And all, at least I know mammals, have an endocannabinoid system. So the rat and the human, we all have to have this system to keep ourselves alive and balanced and thriving. So however much detail you'd want to go into depends on your field. In medicine, we want to know about the endocannabinoids. There's a lot of drug development that's going to be coming out of this. It already has. We need to know where those receptors are in general. The second pillar is to describe what is the cannabis plant, the parts, understanding that differences in cultivation and processing can change the way the chemical profile turns out. What are the differences between pharmaceutical-derived and whole plant cannabis products? And how do molecules transform into others? And for instance, decarboxylation, when you heat up the acid base of THCA, it turns into THC, which is the active intoxicating form of THC. So we need to know basics. And as a medical student, that's up to curriculum planners to decide how much do they need to know. They don't need to get a biochemistry and horticulture degree. They need to know some just solid basics. And then, of course, all lectures will have this kind of map here and to understand that the cannabis plant is extremely complex, which makes it extremely difficult to study. But it is studyable, but we keep discovering more cannabinoids, more terpenes, more phytochemicals. And so there's so many variables to control. It's a plant. It grows. It'll be different in every growing situation, every climate. The third pillar is about the regulations in the US and how that has implications for your clinical practice. We want to go through the history of how prohibition came. It's so very political, if you haven't caught on to that by now, very political, very charged with a lot of problems with racism and all kinds of misinformation that has come about, which I think has really led to just a limbo happening scientifically about this plant, and stigmas that we need to overcome, yet healthfully realize it has its risks and we have to understand them all. So we talk about prohibition, we talk about how racism has also impacted drug policy and healthcare, which we know, and recognize the impact of this federal policy it's had on cannabis research. So we are behind the 8 ball, but we're going to be catching up with the change in scheduling cannabis to Schedule 3 most recently. So this is from a commentary that was written and released the same day that our article was released. And we had no idea that there was an invited commentary that JAMA had requested from Dr. Darshan Mehta, who's a colleague of mine at Harvard, an internist educator. And I love this quote he makes. I'll read it out loud. Moreover, cannabis education is intrinsically an issue of health equity. Underserved populations are more likely to self-medicate when formal healthcare access is limited. When clinicians lack knowledge, patients face misinformation or unsafe use without medical support, e.g. pregnant individuals and individuals with mental health conditions. So this is not just some new drug that's coming out on the market. It's charged with so much emotion, culture, policy, money, the science, and it's already here. So we are catching up as a profession on the back end, trying to learn about this in more ways than just its toxicity and addiction and dependence risks. So more about policy. You have to know as a medical student, actually as a human being probably, what's legal in the US, what's legal in your state, what are the ethical considerations. We're not legally bound to certify patients. You have the choice not to. And we have to understand that. What qualifies a patient to get a medical cannabis card, and what are the challenges they have. And it's not just, oh, my doctor is uncomfortable with this, but I have patients who just don't know how to get their certifications done on the computer. They don't have access to technology. And even when they do, it is a pretty confusing process to get that card online. It's also a cost out of pocket, not covered by insurance. And then we'll talk about, you got to know what the US schedule of controlled substances are, which will be changing very soon. So currently cannabis is on Schedule 1, with the Department of Justice being charged to change it to Schedule 3, which is qualifies drugs with a moderate to low potential for physical and psychological dependence. So Schedule 3 drugs, drug abuse potential is less than Schedule 1, and Schedule 2 drugs, but more than Schedule 4. So it's a good start. It still doesn't mean that you can go to the dispensary and all of that is still legal to go across states. So it's very confusing what this means. But I think this will help, at least the research aspect, to help free up some of those bureaucratic red tape, those bonds that keep brilliant researchers like Dr. Gaudino from having easier access to product and study it in the lab and in people. And then going to number 4, you can see that the subcompetencies get more complex, because what's the evidence base for the actual health conditions commonly managed with cannabis? And I'd say in the medical scientific community, this is the most controversial, because what's what I find evidence is good enough for me as a clinician is not good enough for another physician who wants to see hardcore randomized controlled trials, unmistakable proof. And medicine is an art. So we have a list here, a long list of many conditions which we know have been treated with cannabis. It doesn't mean there's enough evidence for it in the scientific literature, but we need to actually call it out, because your patient will ask, hey, I heard that cannabis helps my Parkinson's disease, when in reality, there isn't the best evidence for Parkinson's, but they're going to try it anyway. So you got to just know that there are many conditions. And why? It's because the endocannabinoid system covers like pretty much every aspect of your body's function. So there's going to be this just multidisciplinary, multi-area that potential for cannabis to help. But also we'll talk about its harms later. So this part's messy, number 4. And this is where you're going to have a difference in curriculum between different institutions. Don't forget, we have FDA-approved cannabinoid-based pharmaceutical medications. And we want to understand the evidence base as those evolve for those medications, and understand the various impacts on inflammation, immune function, metabolic, neuroprotective, and hormone modifying properties of cannabinoids. Maybe, and this is more of a tickler, but maybe cannabis can have a cessation or reduction of pain medications, including opioids and benzodiazepines. And to talk about that role, I clinically have seen that many times, taking patients off of their Ambien, their benzodiazepine, reducing the Norco use. As a clinician who's certified over 1,200 people since 2014, I have been able to help patients do this, but it doesn't work for everyone, but we need research to prove that out. 5th pillar is to understand the risks. And boy, we know a lot about this. Thank you to the National Institute for Drug Abuse, NIDA, which has been dedicated to this and other substances. And we know plenty about the acute and chronic side effects of cannabis. Physical and mental side effects and driving. What's the difference between smoking, vaping, edibles, topicals, the risks to kids and adolescents and pregnant lactating women using cannabis, and the effect on older adults. So we should all have this actually pretty well in hand now, because this has been in the educational world for a really long time. But the problem is we need to know what its beneficial effects could be too. All right, disturbing photos on the right. Okay. More risks would be the cannabis-related disorders using the DSM criteria, like cannabis use disorder, withdrawal syndrome, and hyperemesis syndrome. And what are the roles of different disciplines in healthcare to help treat those cannabis-related disorders? How do you manage them? And understanding potential risks, we can talk about harm reduction, utilizing medical cannabis. This needs a lot more research. This is coming out, but we wanted to be forward thinking in the curriculum that, if that slide says, well, there's still no evidence, then you say that. But at some point, maybe 15 years from now, we'll hopefully see a lot more evidence now that shows here's what it really does. Instead of in our mind thinking it's a good idea, it actually is put to the test, in the lab, in the clinics. And we also need to have a healthy respect for understanding alcohol and other substance use, like, goodness, the one legal drug, alcohol, which has a lot more implications on the human body than cannabis does. It just tends to be put to the side because it escaped with prohibition that went away. I have a lot of opinions about that, but who was in charge of the alcohol industry were, the white dominant culture. So, that is the substance that has made it through and is just part of our culture, totally accepted, but has a lot of problems fraught with addiction and driving incidents and violent crimes and such. So anyway, put it all in perspective. Cannabis is not an angel by itself, but put it all in perspective here. We have to understand the potential risks, again, more about quality production quality concerns. There can be issues with contaminating with mold and the mycotoxins they produce that can make people sick, pesticides used to keep the bugs off, heavy metals, bacteria, and solvents that will be used to make the vape cartridges and the oils and such. We have to have a general knowledge about that as a medical student. And then for those in the industry that actually make this stuff, this is all of their, like, a huge part of their lives. Let's learn also in that, under that pillar, about novel synthetic cannabinoids like delta-8 THC and the things that are being cooked up outside of regulation. This is all being pushed away now with legislation, but it's very controversial right now. But I know that delta-8 THC is intoxicating, and I don't know about in Illinois yet, but I think it was really easy to get. It may still be easy to get as they're starting to clean up the intoxicating substances that are available in gas stations and in vape shops, because delta-8 THC's kind of skirted the delta-9 THC limitations. So it's, I mean, we know just how do you enforce safety and get it to be consistent across the board. This is, again, something to be aware of. And that delta-8 THC is not the only cooked up new synthetic cannabinoid. There's delta-10. There are others. There's K2 and spice, which are really not, they get conflated with plant-based cannabinoids, but they are not the same. And I have colleagues who think it is all the same, and this is where education comes in. They are not the same. But and it makes cannabis all bad. There will always be bad actors that throw in their bad cooked up things into the mix, causing more ER visits, toxicity, lethality, and such, tainted products as well. That part needs to be really controlled much better. More about risks. What are the financial and occupational hazards of medical cannabis use? For instance, if you're a airline employee, a flight attendant or a pilot, like, you just can't use it. You can't take it across state lines. You need to know travel restrictions, and also understand that getting cannabis, medical cannabis for patients, is an out-of-pocket expense. So that costs money. And what about drug testing? So these are very pertinent to our patients. Got to know this, and it will be changing. Number 6, finally, moving on to the last pillar, is to understand how do you help a patient manage cannabis? If they're going to use it therapeutically, we should be the ones, the professionals, guiding this. But right now, it's the dispensary staff, as it should be to a certain point, and the internet and their friends. And so we are so behind as a healthcare profession in this, and that's why we did this. We need to establish the competencies and get this into the early training stages for physicians in med school. Got to know your routes of cannabis intake, dosing, and monitoring. Develop a treatment plan, just, a basic one. Know your pharmaceuticals as well. And how do you deal with experienced versus naive cannabis users, because they are going to have different regimens. And this is where I've learned it kind of the hard way. Like, I would see a geriatric patient that heard that cannabis helps, and they just eat 1 or 2 edibles at night to start, and then they're dizzy as heck in the emergency room. You definitely want to start with 1/4 of that piece that this woman is holding in her hand, or even 1/8 of it, and just wait and increase the dose the next evening by a little bit more and a little bit more, until the desired effect is achieved. A little pearl right there. And there was a question ahead of time asking if I would talk about the natural derived versus pharmaceutical products. And I wanted to just tell you about consumerlab.com. I have no relationship with them, but they do a nice ongoing review of over-the-counter CBD hemp-derived products. You have to subscribe to it. It's about $50 a year, I think. Very worth it. It's the only one I know that's around that does this level of testing. And they will have, they look at what's in the label is actually in the bottle in their testing labs. Then they look also, was there THC detected? This is This product down here, the second one says it has 0.66 milligrams of THC, which is it's still there. So if you want someone with zero THC, then maybe you go with this formula right here. I have no relationship with any of these products, but this is not a CME lecture, so I'm going to share brands with you. And then they go through what the label recommends. So I really like this because I don't have time to go and send my own products out to a lab and figure it out, because this is expensive to do. This does not cover every single product ever made, but I like this a lot. Then you have to know your pharmaceuticals. So there's basically only 3 that I'm aware of. The CBD plus THC, which is probably mimics most, and full like cannabinoid plant substance, has not been available in the US. It's Sativex. It's indicated for multiple sclerosis spasticity only. At some point, though, with Schedule 3 happening, I'll bet you we're going to see Sativex coming to the market. But right now in the US, we have Epidiolex and we have Dronabinol. Brand name's Marinol for Dronabinol, but the CBD only formula is for pediatric seizures and Dravet syndrome. So as much as I'd like to say, well, why don't we just use pharmaceuticals for everybody? Well, yeah, but your insurance isn't going to cover it for your for your condition if it's not pediatric seizures with Epidiolex. With THC, Dronabinol is indicated for HIV-related wasting and cachexia, or for chemotherapy-induced nausea and vomiting. So that's it. And it's such a convenient thing to say, let's just wait for that stuff. And if that's all you're comfortable with as a clinician, go for it. But you've got a very narrow box of conditions you can use. Plus, you're going to have quite a bit of prior authorization paperwork to write up. So anyway, and if you can, great. Hope more products are developed along the way. More along clinical treatment plans is you got to know the differences between THC predominant and CBD predominant formulas. Also, that there are entourage effects that happen when you combine terpenes, flavonoids, and other biologically active constituents, which you will find in whole plant products. I didn't even mention the difference I should put in there, indicas and sativas. And right now, everything is so hybridized that the general rules of thumb that indica is for the people who need to be into bed, sedating, body melt, pain reducing. That's what indicas are known for. And sativas are more known for the mental effects, the creativity, the euphoria, the giggling, but also can be more paranoia or anxiety causing. These are some general feelings about indica versus sativas, but so many products are hybridized, so you probably can't predict it all that well unless you're using the landrace or what we call the heirloom varieties, where they really stayed true to their genes. This is a very GMO, genetically modified group of plants. So anyway, it's just something to know, and it just adds to confusion. On the right side is a label, an idealized label of what I wish every product had, but this is not what products have. If you actually have seen what's coming from our dispensaries in the tiniest print, you only see THC and CBD ingredient lists. But I would love if we'd have a lot more quality control and flesh out what are the other cannabinoids, what are the terpenes and flavonoids, so that perhaps you could predict a little bit more of what this product will do for your patient. But right now, I just go with how much THC is in there. Let's start with not too much and let the THC drive the dose. As part of clinical planning, you got to know what drugs might interact with this, know about your cytochrome P450, liver enzymes, and know a bit about your patient's pharmacogenomics if you can help it. But they definitely impact how medications are metabolized if they're on something at the same time. And then know also that there are some conditions in medications where you don't want to use cannabinoids, like immunotherapies and cancer treatment. For instance, Keytruda and cannabinoids might interact, or the cannabinoid interferes with the Keytruda's ability to fight cancer, And there's a potential for treatment failure, which is like the last thing you want when you're treating someone for cancer. But even that evidence base is mixed. But right now, that's the feeling. And until somebody does a really good trial to either refute that, or that's what we're saying to this date. More along the lines of treatment planning is, how do you use your colleagues in medical cannabis management, your pharmacists, your nurses, social work, addiction specialists, toxicology, and also understanding how each population may be using cannabis differently or not to be using cannabis. Geriatrics, peds, pregnancy, palliative care, pre and post operative. There's some rules of thumb in each group. And this is a lovely family that the girl on the right is Ashley Surin, who had cancer at a really young age of 2, developed seizures, and they figured out how to get her seizures under control using low-dose cannabis patches, low-dose THC. She's been seizure-free since she started this, and so they're having a hard time finding the patches because the manufacturer left the state. So there's a lot of stuff that's going on, but they helped create legislation that allows her to use the cannabis at school in a very specific way, with the school nurse helping out instead of her mom having to take her home every day and skipping school altogether. So there's a lot of this is mixed in with legislation and policy, of course. Okay, so this commentary, more awesome quotes from Dr. Mehta. The competencies proposed by Zolotov et al. Should be mandated and integrated, not relegated to optional electives. Medical schools and residencies must embed cannabis training alongside opioids, benzodiazepines, and insulin, not as an afterthought, but as a core clinical domain. That's my favorite quote from this commentary, and that's why we did this, because our patients are using it, and whether or not a person agrees with it, or they agree that the research is there or it's not there, you better know it, because your patients are very highly likely using it. But there are challenges to implementing new med school curriculum. And on February 2nd, I'm going to be joined by Dr. Adi Haramati from Georgetown. He's a longtime educator in the physiology department, and he is not a cannabis clinician, but he knows curriculum planning, and he knows, because he's been part of the ACGME on high-level international committees on med school education. So we know that the curriculum is crowded. How do you get questions on the board exams? Because that's how you get curriculum into med schools. You put the test, they put it on the test. Otherwise, the students aren't as motivated to study for it if they're not motivated. And who will teach this if there are no faculty who are comfortable with the topic? So we have a lot of catch up to do there. And what depth of knowledge do med students need to know? Because I highlighted a very complex curriculum. And remember, these med students are absorbing so much information. You'll learn more in residency, and you'll learn more in fellowship. And then when you're a clinician, you'll learn more. So we just don't need to have that basic grounding. And there's so many students that are feeling behind. I took the liberty of looking at the UIC College of Medicine's med school curriculum, and this is what they do in years 1 and 2. Different block rotations, different subjects in year 3. Then they start going through their specialties for various numbers of weeks. And then I highlighted, I'm a family medicine physician, so I looked at the 6-week family medicine curriculum and found here that in family medicine, their clerkship during year 3 covers these conditions. And whoa, guess what? People use cannabis for anxiety, arthritis, not asthma. They should not use it for asthma, COPD, but definitely they use it in chronic back pain. And you got to know that it can increase your risk of coronary artery disease if you smoke it, particularly. Definitely people use it for depression and the insomnia. Heart failure goes with the heart stuff. So in every one of these conditions here, there is some sort of condition that someone might say, cannabis might help with that. Maybe, I don't know about osteoporosis. I guess you could indirectly say that People need to do weight training, but if you have too much joint pain to weight train, then the cannabis helps me so I can exercise and have less pain. So you could figure out some way around these, but there are many of these conditions you could incorporate something about the endocannabinoid system and the evidence base for or against treating cannabis for the symptoms that come out of these. That's just family medicine. Remember, we've got like, what about neuro? What about the pre-post-op patient in pain? What should we do in anxiety, PTSD, etc. So anyway, you can see lots of opportunities to incorporate this, but family medicine doctors have to know so much. Acute conditions, we need to talk about adult health maintenance, well adolescents and well child. It's a lot to cram in during residency training as well. And so in year 4, we know that in order to graduate, you have to do a sub-I. I won't bore you with these, but again, more opportunities to start diving more into their desired field, and you could figure out how cannabis might be incorporated into that if needed. And some strategies just ahead to tease you about February 2nd, and Dr. Harmati, is that we have a call to rapidly develop modules. Residencies must integrate hands-on clinical experiences or simulation scenarios, and we should be adding didactic and case-based cannabis content starting in year 1 with reinforcement and clerkships. This is from Dr. Mehta from the JAMA commentary. And then I'm saying create a question bank on the endocannabinoid system at least, and medical cannabis based on these 6 competencies for the board exams. And you have to periodically review these to make sure they're still relevant, there's still fidelity to the evidence base, and because more knowledge is going to be attained, especially now that we're going to Schedule III. And as Dr. Gaudino has mentioned too, he's in a conversation we've had, it's like, now that Schedule III, we're like, there should be a fire under everyone to get caught up, because now you have like, I mean, I'm still not even sure what to make of that, but it happened slowly and quickly. We need to catch up now. It's Schedule III. We need to know it like we know other Schedule III substances. And we need to also be multidisciplinary with mental health, nursing, pharmacy, PT, OT, and social work, and more. I'm sure I'm missing someone there. And of course, our industry, the people who are touching base with our patients one-on-one, cannabis dispensary staff and industry need to be also caught up. Okay, I think that's it. This is not just reform, it's a reclamation of our professional mission. Physicians are healers guided by evidence and oath, not outdated legal definitions. Delay in clinician preparedness translates into preventable harm, perpetuated stigma, and a failure of trust. And this is a roadmap. So it's a call to action. This paper is, and we now must act. Medical cannabis is here. Will physicians catch up, or will we, through omission, continue to let patients navigate therapeutic uncertainty alone? So there's your guilting statement. And so, again, another reason why 74%, why is this important? 74% of Americans live in a state where cannabis is legal for recreational or medical use. 74% of Americans. So even if you're in a state that's still totally illegal, you better know it to some degree. So thank you very much. I think I've this time left some time for questions. I still went over, but I will leave it there for our follow-up to how do you incorporate this into curriculum from Dr. Harmati.
Thank you, Dr. Temple. That was great. And I think we're going to move to, we do have some time for some questions. Okay. You actually already mentioned it live. It was, is there a major focus on natural product extracts from cannabis or hemp or both? And I'm assuming that this is in relation to the curriculum that you're talking about. Would that curriculum be natural product extracts from cannabis or hemp? Would it be focused on some of the pharmaceutical preparations, that kind of thing? So
It should be on both because I think it's about access. So if your patient is going to go to the dispensary and just pick up this stuff and it says, oh, I got this Charlotte's Web CBD hemp. What do you think, doc? You better know it. So that should be part of the curriculum because that's so easy to get. So you should have a really good knowledge. And that's why I shared the Consumer Lab website because it at least guides you on some good formulas that they could at least try if they're going to. And then the pharmaceuticals you have to know because just like any drug, you got to know your beta blockers, you got to know your statin medications, opioids. You also need to know if this patient's a candidate for a Epidiolex or dronabinol and one day Sativex. The good, easy part, I think it's easier to learn the drugs because there's only three. No, actually, the US, there's only two. Boy, I mean, so you're gonna, that's a really quick lecture right there. Then the other part, we should always have a good, like, how do you write a prior authorization for a Epidiolex? And in the end, the it's the Epidiolex is probably the hardest drug to prescribe because it's pediatric seizures. So you're usually seeing a peds neurologist for that because the patient has already tried multiple anti-seizure medications. And so, by the time someone's gotten to Epidiolex and got it covered by insurance, they've probably been through multiple rounds with a specialist there. So it's probably not a primary care thing to know. You should just know it exists. And I haven't tried to prescribe it yet because I haven't had the opportunity yet. But I have had the chance to talk to my pediatric neurology colleagues who send patients to me for the acupuncture and the dietary recommendations. And if I don't bring up a Epidiolex or I'm like, did you think about that? They probably did. And that way you're literate in all of this. But your education in that sixth pillar is probably going to be more about the natural products than the pharmaceuticals when it comes to actually talking to patients. Oh, actually, Robin Mermelstein has a question. I see her hand up.
Yes, Robin, please
Yeah,
unmute.
I promise I
thanks for a great presentation. And I'm struck by how not unsimilar this is in terms of when we tried to get tobacco education into medical schools and how not still, despite that very strong, obviously, need for people to know about the damages from tobacco and nicotine and the challenges today as as well. So not dissimilar to what you're saying with the the trying to get more about cannabis in there. But in your curriculum, it's interesting since it's very much about, okay, here's what you need to know for prescribing for medical, but there's also the side about what do you need to know for identifying a cannabis use disorder?
Mhm.
And the attention to that or resources. So just like with tobacco is like when do you worry or how do you refer people? Part of the curriculum, didn't seem to be how do you appropriately engage in those decision making or change discussions with patients.
It should be in there, but it was I probably went over it fast trying to get done on time. Um, and let's see, I think that's pillar the attend and understand pillar number 5, which is understand the potential risks of medical cannabis use. Other than the acute things, in there is understand the roles of interdisciplinary healthcare professionals in treating cannabis related disorders. So you and the other sub competency is describe managing cannabis overdose and intoxication. That is where, as a medical student or a physician, I'm like, I need to be able to recognize it and then refer. If I'm going to treat it myself, that can, of course, be developed more in the curriculum. These are guidelines, so they're not going to have as, I don't know, if we're missing something in the language here, maybe it wasn't as clear. I'll share my screen again here.
I mean, I
That
also
what you're,
just have missed that then in terms of
yeah, I was
yeah.
talking fast, but
Yeah,
we
no,
definitely,
yeah, I think in there it was more of understanding, yeah, in treating cannabis. I was thinking of it within the context of your talk, more of like if you have hyperemesis or things like that, as opposed to
Mhm.
the problems of, a cannabis use disorder per se, but understanding that. And then, of course, the other part, which I think is really critical is the lack of any assessment. People don't normally ask even. You know,
Hmm.
you made the excellent points that you need to know because of interactions and other things. But most healthcare providers don't even ask if their patients are using.
Hmm. Yeah. I mean,
And I think in addition to that is not only are healthcare providers not asking, but because of the stigma, patients aren't volunteering, right?
Right.
So that creates an even bigger problem because there are potential contraindications. High doses of CBD are known to impact certain types of drugs, and so on and so forth, right? So there really does need to be some sort of an open dialogue to be able for healthcare practitioners and patients to actually have intelligent conversations that are directed towards their wellness, right? Their health concerns and wellness. So
Exactly. And you have this generic question about do you use drugs? Or and most people who are using do not consider it a drug.
right, right. So
So
you have
I
to actually ask, are you using cannabis? Do you use an edible? That's probably in like the lay term, the most common way. Or do you smoke a joint or vape
right.
marijuana? Like, do you? And you
And
could,
knowing right, and knowing that route of administration is also really
so
important.
key. Yeah.
So it's I think that's sort of a fundamental part in the
Mhm.
curriculum and but that's a systemic change of how do you destigmatize to ask about it.
If you had so much time in a visit, right? It just leads to so the challenges. I mean, if you saw the way we laid out the curriculum, I mean, how would you even be able to go over what you said we need to talk about? There are like four other pillars to discuss in a. How would you implement? Are you an educator at UIC or part of?
I mean, I work with people who have both tobacco and cannabis
I
use
see.
problems, but not, I don't teach in the medical school, but no,
Okay.
but having done those challenges, I used to teach having to do the tobacco curriculum. And
Yeah.
there's just helping people understand all the different implications is important too.
Yeah, I remember Tar Wars when the IAFP came out with these like programs to help incentivize physicians to teach about their patients about the hazards of tobacco use. It's hard because the educational piece is going up against limited time with your patients and limited time on in the curriculum. And that's the whole purpose of this curriculum is it's where it's not a cannabis is all good or all bad. It just is what it is and the knowledge is going to be changing frequently. So we had to start somewhere with these competencies because once you get everything kind of laid out in an organized format, then if you're in the addictions psychiatry rotation as a medical student, then you'll get this much more fleshed out. Your questions, your concerns are going to be, a really good topic for that day's lecture. But let's say you're in the I don't know, you're doing your pharmacology and you're talking about opioids today. Then you're going to talk about the endocannabinoid system and the effects of cannabis. So I think that the questions that everyone has on their mind that's relative to their personal interest will come out in the class that you're taking. And it's going to require a big shift in how the educators are making their presentations. Um, but to have a very balanced viewpoint is what we want, that it can be good, it can be bad, but it just is what it is.
Yeah, no, thank you for a great presentation. Of course, the other
Thank
part of the challenge is that many of the people who are in the classroom will be using those products as
you.
well
Mhm.
too.
Yeah.
yeah,
So,
Yeah.
so having to be sensitive to
yeah.
who's in the room. But
Hmm.
thank you very much.
Thank you.
I just want to jump in here and say that Dr. Mermelstein is being quite understated. She's actually an assistant dean at the UIC College of Medicine, and she's run a number of different programs, including with substance use and as part of the psychiatry department. I just wanted to make sure that you knew that She
Okay,
is
yeah.
she is a recognized authority on some of these topics. So, um,
We also
I
have
think
one
what,
question if there's time.
oh yeah, yes.
It is in the Q&A and it says, how could this framework be realistically integrated into medical training, continuing education, so it actually changes clinical behavior as opposed to just being a conceptual guideline?
Mhm.
I believe some of this just got covered by the previous conversation, and I think this is also something that we may be covering in February too, but on February 2nd, but definitely wanted to give you the opportunity to speak to that, you and Reggie.
Yeah, so that's a teaser to February too, definitely, because I only touched upon it in like 1 or 2 slides. How you start off, first of all, you have to find a champion that feels comfortable with the therapeutic use of cannabis. Because to Dr. Mermelstein's point, if you're seeing the addiction side and, I call it the dark side, the downsides of using it, and that patient is saying, well, I heard it helps IBS, so I need to know, I'm using it for IBS, and holding on to that feeling of truth, and it keeps on fueling their ongoing use in an unhealthy way. You should know the evidence base for IBS and go, did you know it doesn't have the best evidence? Like you should, that's how you use that information. But if it's the faculty that's going to really drive this, because if they really have experience with it, and that's hard because it's not like everybody suddenly has become, a cannabis expert and using it on their patients. So in the meantime, the faculty, whoever's in charge of whatever lecture, should be incorporating something about the endocannabinoid system or knowledge about people probably use cannabis for this. So just proactively add it into their presentations, or the idea when they're talking to patients, it should be on the mind because it's very likely being used, whether you approve or not. We had a similar thing happen with integrative medicine, like the use of herbs and supplements, and how often patients don't tell their doctors, I'm using vitamins, for fear of being rejected or they're just going to be blown off. Because that's really where my experience first comes from. So knowing about cannabis naturally came into my field because so many of the conditions that Illinois covers, those are my patients: fibromyalgia, cancer, multiple sclerosis, chronic pain syndromes. Of course, I better know about cannabis because my patients will ask, and I don't want to be behind. So to the question about how do you implement it, we're going to get really granular, hopefully granular about it with Dr. Haramati.
Okay. Thank you everyone for joining us. That's about all the time that we have for today. I want to say thank you again to Dr. Leslie Mendoza Temple for joining us and to helping us understand this. And I encourage everybody to come to our February 2nd discussion with Adi. What was the last name again? Sorry.
Haramati.
Aramati, thank you. And if we could have that last slide there, our last slide there.
I think it's in the chat. There we go.
Oh, is it? Okay.
There it is.
And so just want to say, if you follow that QR link, you'll be able to stay connected to us. You can subscribe to our newsletter, visit our website, follow us on LinkedIn, and we hope to see you again in some of our future research series. Thank you very much for joining us.
Thanks everyone for sharing lunch with me. Us.